Hi, welcome to the Brain and Heart Week with several activities promoted by the World Stroke Academy from World Stroke Organization together with WSO Brain and Heart Task Force. My name is Sheila Martins. I'm President-elect of World Stroke Organization, and we will start today with the Paper of the Month, a new initiative promoted by the World Stroke Academy. I'd like to ask to Gustavo Saposnek, that is the chair of World Stroke Academy, to talk a little bit more about the initiative. Gustavo.
Thank you, Sheila, and good morning, good afternoon, or good night to everyone. Being cognizant about the different times scheduling. So I'm one of the editor-in-chief of the World Stroke Academy. The World Stroke Academy is the educational platform of the World Stroke Organization. And this is a new activity, and this new activity is about illustrating and highlighting the paper of the month. This is part of the section editor. So this month, we have the privilege and the honor to start and highlight a publication in JACC, in the Journal of American College of Cardiology, from Luciano and you guys in terms of as a team, regarding the connection, a review article on the heart and brain connection. And this is worth reading this article to better understand how much we have been missing and an opportunity that we should take on in the near future. So thank you very much for joining today. And it's a great pleasure for all of us to initiate this activity. Sheila, thank you.
Thank you, Gustavo. To talk about this, we have here the authors of this amazing paper. And on Wednesday, we will have a tweet chat discussing the paper and this topic with the authors. The authors are part of the World Stroke Organization Brain and Heart Task Force. So before to talk about the paper, I'd like to ask to you, Luciano, introduce yourself and tell me about what is the Brain and Heart Task Force and what the main goal.
Hello, Sheila. Thanks for the introduction. I'm a stroke neurologist at Western University in London, Canada. The task force was created to bring or increase awareness about the relationship between the heart and the brain, or the brain and the heart, and how they interact, and to help people around the world to be able to better coordinate the treatment and diagnosis of patients who have both heart disease and stroke, or even heart disease caused by stroke, as we will be discussing in this paper. So the task force is working on several projects that will hopefully take off soon, and then they will help other people around the world to better tackle this association.
Perfect. Thank you, Luciano. Now for Jan, introduce yourself and tell us, what is the stroke heart syndrome?
Recording. So thank you, Sheila. I'm a stroke neurologist at the Charité University Hospital in Berlin, Germany. And yeah, my major focus of research is the heart and brain interaction. I have a dedicated research group called Integrative Cardioneurology. And yeah, I'm really happy to promote our JACC paper here today. Actually, the stroke heart syndrome, which you mentioned, is one of the major concepts that were highlighted in our JACC paper. And our paper expands on the previous review from me and colleagues from Berlin, published in the Lancet Neurology in 2018. And in brief, the stroke heart syndrome comprises a broad spectrum of cardiac complications that occur as a direct consequence of a stroke, or are at least triggered by the stroke. And it ranges from asymptomatic ECG alterations and biomarker elevations, such as cardiac troponin, which may occur in up to 50% of patients with stroke. And it leads and ranges then to even more severe complications like heart failure, arrhythmia, and even sudden cardiac death. We know that the stroke heart syndrome peaks within the first 3 days after the acute event, and that approximately 1 out of 7, 15% of patients suffer from more severe forms of the stroke heart syndrome. We know also that risk factors are older age, premorbid cardiac disease, and also stroke characteristics such as higher stroke severity and stroke location, especially when it comes to strokes affecting the central autonomic network and especially the insular cortex. So what we know in very brief is that stroke heart syndrome can be considered to be the result of a stroke-induced stress test for the heart.
Perfect, Jan, thank you. Now for Cecilia, could you introduce yourself and tell us what is the global burden of neurocardiogenic?
I'm Cecilia Bajit. I'm a cardiologist from Argentina, and I'm pleased to be part of this group. And I think, as Luciano mentioned, it is very important to let people know about this and to disseminate the information. So we know that approximately 1.5 million deaths around the world are related to neurocardiogenic syndromes. We know when the patients die due to that. The reality is that we don't know the numbers of the incidence of the events that are not counted as dead. But as it was mentioned before, this stroke heart syndrome includes a variety of conditions, including myocardial injury, post-stroke infarction, left ventricular dysfunction, heart failure, EKG changes, arrhythmias such as atrial fibrillation, post-stroke neurocardiogenic, sudden cardiac death. So these are all very important conditions that we need to keep in mind and to follow and to increase the awareness for that.
Perfect, thank you, Cecilia. Now for Santosh, introduce yourself and what can you tell us about post-stroke Takotsubo syndrome?
Hello, everyone. My name is Santosh Murthy. I'm a vascular neurologist and a neurocritical care physician at Weill Cornell Medicine in New York City. And a big round of thanks to both the World Stroke Organization and the World Stroke Academy for this opportunity and for highlighting our paper. So as far as Takotsubo cardiomyopathy is concerned, I mean, it's essentially defined as a left ventricular dysfunction. And we tend to see this fairly frequently after an emotional trigger, a physical response, or even after an acute brain injury like a stroke. And this sort of highlights the intricate relationship between the heart and the brain, which is the focus of our task force. And essentially what we have seen is, over the years, people have reported different patterns of left ventricular dysfunction. It could be the apex, it could be the mid-ventricular, the basal. Now, regardless of the pattern of the dysfunction, it is essentially now well recognized that Takotsubo can encompass any sort of left ventricular dysfunction and is an important cardiac complication after stroke. It's most commonly seen after a hemorrhagic stroke, in fact, 10 times more common after a subarachnoid hemorrhage than it is after an ischemic event like an ischemic stroke. Previously, we all believed that since the cardiac function more or less returns to normal in about 3 to 4 weeks or so after a Takotsubo event, that these events are fairly benign. But over the course of the years, with more research, our understanding of this pathophysiology has improved to the point that we now know that if you were to have a Takotsubo syndrome, then it increases your chances of mortality and poor outcome by 4-fold after an acute stroke. So clearly, we need to pay a lot more attention to these. And even patients who survive Takotsubo syndrome, they long-term are at an increased risk of acute cardiovascular complications like acute strokes, MIs, and cardiovascular mortality. So as cardiologists and neurologists, we need to be paying more attention to these patients, both from an early aggressive screening perspective, and I think from a long-term therapeutic strategic perspective.
Perfect, thank you. We will talk more about this on Friday in the webinar too. Now for Sarah. Sarah, please introduce yourself and tell us how frequently is cardiac troponin T found to be elevated among acute stroke patients? What should neurologists do when cardiac troponin is elevated in stroke patients? And when to consult a cardiologist? This is a challenge for us.
Thank you, Sheila, and thank you for this opportunity to discuss our paper. My name is Sara Asperg, and I am a cardiologist working at Norrtälje Hospital and Karolinska Institutet in Sweden. Well, the first thing I would like to say is about the clinical problem. We should be aware of the clinical problem implicated by elevated troponin elevation. Somewhere, depending on the kind of assay you use, somewhere between 30 and 60% of all patients with stroke will have elevated troponin levels, and elevated troponin levels are actually one of the strongest markers we have for worse prognosis. So the first thing I think we should think about when we see this kind of patient is the reason for the elevated troponins, or the reasons, because when we understand the reasons, then we can kind of decide the kind of intervention we would like to use. And actually, guidelines-based, quite simple tools like ECG or extended 24 hours, at least 24 hours of rhythm monitoring, or echocardiography, or serial measurements of troponins are quite useful tools when we try to understand the reasons for the troponin elevation. Sometimes we have to do more extensive evaluation, but once we have kind of figured out the reasons, then we have to work together. Then we have to work together as neurologists and cardiologists, because the way it's kind of easy for me as a cardiologist to think of ways to handle secondary or primary ischemia in the heart, or how to handle heart failure, or to relieve stress for the heart with beta blockers. But the best cardiac therapy may not be the best therapy post-stroke. We have to balance bleeding risk versus thrombosis and risk of thromboembolism. We have to find the right levels of blood pressure control. And of course, we have to individualize the therapy, because naturally many of the patients are old and have severe strokes and high bleeding risk, and may not be suitable for a more than a conservative strategy. So we have to discuss patients together. And of course, it's important to identify the part of the patients with acute coronary syndromes, but they will not be the major part of the patients with troponin elevation. And finally, it is important not to forget about follow-up, because in many cases it's kind of easy, because the same chronic atherosclerotic disease will both cause the ischemic stroke and the chronic ischemic heart disease, and then you need the same kind of secondary prevention. But sometimes you need a more specific cardiac evaluation and follow-up. And then once again, we need to work together.
Perfect. Thank you, Sara. Now again for Jan, could you expand a little bit the concept of rise and fall? And are there any ongoing or expected studies in this field?
Thank you, Sheila. I would like to expand on what Sarah just said. So the topic regarding troponin elevation is really a major part of our paper. We give some advice how to interpret troponin levels after stroke and how to deal with it. And the rise and fall pattern plays an important role to distinguish acute from chronic myocardial injury. And this is important in order to establish the most likely cause of troponin elevation. And if there is a rise and fall pattern, which is typically defined as a 20% or 50% change, if it's closer to the upper reference limit, then further diagnostic steps should be made immediately to identify patients with higher likelihood of ongoing myocardial infarction. And yeah, with regard to ongoing studies in the field, I would like to mention the PRAISE study, which is a multi-center study conducted in Germany that aims to identify predictors of acute myocardial infarction in stroke patients with elevated troponin levels. And all patients receive diagnostic coronary angiography for this purpose. And moreover, we and others around the world are also apply cardiovascular MRI to identify myocardial tissue alterations that are associated with troponin elevation. So yes, there are a lot of studies with results to be expected within the next few years, and we are really looking forward to it.
Perfect, thank you.
For Luciano again, what is stroke-induced heart injury? And what are the main take-home messages of this paper?
Thank you, Sheila. Yeah, stroke-induced heart injury, or SIHI as we call it, is the pathophysiological process that leads to the stroke heart syndrome, right? It's the sequence of events that end up causing a stroke heart syndrome after a stroke. And it has two main components. One of them is autonomic dysfunction, which expresses as a catecholamine surge, which reaches the heart and causes toxicity there. And then there is an inflammatory component which has a central role for interleukin-1 beta. And that's how things happen. But to get into more detail, we can say that SIHI has three levels of action. The first one is at the level of the brain, where there is inflammation that is triggered by the stroke. And that inflammation persists quite for a few weeks, I would say at least 4 weeks based on experimental studies. And that same inflammation is the one that releases interleukin-1 or favors the release of interleukin-1 from the brain into the bloodstream. So then it comes to the second part, or the second level, which is the systemic level, in which interleukin-1 acts over the adrenal glands, for example, triggering the release of catecholamines. It acts over the autonomic pathways within the brain, brainstem, and spinal cord, and that leads to further stimulation of the spleen, for example, through the autonomic nerves and releasing more inflammatory markers or inflammatory cells. The spleen and the bone marrow are stimulated by interleukin-1 beta, and they both produce a lot of monocytes or macrophages or neutrophils. They become activated and they're released into the bloodstream, and that enhances the inflammatory response. And then we have a third level, which is the cardiac level or the myocardial level, in which all those catecholamines that were circulating in the bloodstream, plus the local stimulation, but the nerves that come through the autonomic nervous system, they both produce toxicity at the myocardial level. And that causes subendocardial hemorrhages. It causes direct myocardial damage, myocardial cell damage. It causes damage to the vessels, causing more acute coronary syndrome. So there's an interaction, a very tight interaction between inflammation and autonomic surges. And at the end, the target organ or most of that damage is at the level of the myocardium, even in patients without prior heart disease or even without coronary artery disease. Those patients may have totally normal coronary arteries, but because of the endothelial dysfunction at the level of the microcoronary vessels, they can still have stroke heart syndrome. And in terms of the take-home messages, I would say that this paper has a lot of interesting features. We provide an updated and very well described definition of the stroke heart syndrome, which was originally introduced by the group of Jan Scheidt in Germany. We provide an insight into what we call AFDAS, or atrial fibrillation detected after stroke, which is a cardiac arrhythmia that has quite substantial differences compared to the AFib that we all know, because it may have some neurogenic mechanisms. And I invite people to read the paper to get into more detail. And then we provide a very extensive description of what happens with troponin after stroke, which is very, very common. We see that all the time, and we sometimes do not know what to do. So that's another strength of the paper. And fourth, we provide a very a very detailed description of SIHI, or stroke-induced heart injury, putting together all the evidence that we have so far in terms of how the heart is damaged after a stroke.
Wonderful, Luciano. The paper is really amazing. You should read. And remember, we will have more about this in the webinar on Friday 26, and we will have a Twitch chat to discuss this with the authors on Wednesday. Before to finish the session and not to talk about injury, Luciano, I heard from you is another topic about the brain and heart connections. I heard from you that you can sync with our heart and you can love with our brain. Do you think it makes sense when we talk, listen to your heart when we have to make difficult decisions? Yeah, this can be a topic for another interview, but you can just introduce the topic.
Yeah, well, the concept is the concept of interoception, right? It means that whenever we're making decision, and we have an expert here in decision making, it looks like when we are about to make a decision, there is some connection between the brain and the heart, and the heart reacts differently when we are about to make a good decision or a bad decision, or when things are tougher, right? And I always like to say that the heart has neurons, right? It's not that it's only muscle, it has neurons, and it communicates with the brain through those neurons, and that's how they are so tightly interconnected.
Perfect. Thank you. It will be a topic for another interview. Thank you all for wonderful interview. Congratulations for the amazing paper, and we wait for you in Twitch chat on Wednesday and the webinar on Friday. Bye-bye.
Thank you.
Yeah, perfect.
Thank you.